good evening to all the aspirants and Dr. Varun Pushkarna too. Well, today topic is cardiology, and the speaker we have here is Dr. Varun Pushkarna, who is the senior consultant in internal medicine at Fortis Escortis Hospital, Amritsar. Over to you, sir. Thank you.
Thank you. So, without wasting much time, let's begin with the class for today. So, cardiology in MRCP is basically I would say it is one of the most uh, encompassing branch. So, when you read about cardiology, you read about some neurology, you read about some cardiac surgery, you read about vascular diseases, and of course, the cardiac pharmacology is huge. So, we'll first begin with the broader case based topics that come to the exam, and then in probably in the next class, we will take individual diseases also. But I just want to bring you to the frame of examination where the questions are framed according to the presentation of the patient. So, we will first discuss the presentation types, a synopsis, and then we will probably go into each diseases. It is not easy to cover cardiology whole of it in 2 to 3 classes, but let's see if I can do justice to it. So we'll begin with the most important cardiology topic. People read about um, hypertension, cardiomyopathies, acute coronary syndromes, heart failure, but then people don't read about syncope. That is one of the cornerstones of question that come to the exam. When you generally read syncope, you read about the neurological syncope. So many times it is missed from the cardiological perspective. So let's see. We all know that syncope is defined as a transient loss of consciousness due to global cerebral hypoperfusion. So this is the definition. That is, it's a transient loss of consciousness due to cerebral hypoperfusion. It could be reflex syncope like vasovagal, situational, carotid sinus, hypersensitivity, um, micturition syncope is also reflex kind of syncope. Orthostatic is dehydration, medication induced like patients on antihypertensives, patients on beta blockers, patients on digoxin. They can have orthostatic hypotension because and diuretics, of course. So so many drugs are there which can cause autonomic failure. For example, diabetes. For example, autoimmune diseases, so on and so forth. So these are the basic conditions where orthostatic hypotension is seen. As far as cardiac is concerned, it is mainly due to number one, arrhythmias. Which arrhythmias? See, syncope will happen in a normal structural heart with ventricular tachycardia and ventricular fibrillations. Although atrial fibrillation, atrial flutter, they can also cause syncope only if there is a poor LV function. That means there is LV dysfunction. Then it can also cause syncope. Then comes the bradycardia part, that is complete heart block, second degree Wenckebach, Stoke-Adams attacks, so on and so forth. Structural heart diseases like hypertrophic obstructive cardiomyopathy. So it can cause syncope. Aortic stenosis, that is a valvular heart disease which can cause uh, syncope. So there are, whenever cardiac comes to the mind, people usually say arrhythmia, and then the list is complete for them. But then I keep asking my students to enumerate more cardiac causes of syncope, and then they just black out. They have syncopes. So it is not only arrhythmia which causes syncope, but structural heart disease like HOCM. Patients present with sudden cardiac arrest. So sudden cardiac arrest is a variant of syncope only where the consciousness never returned. Syncope is where we know that it was just a transient loss of consciousness. Then is aortic stenosis. And then history clues are important where we need to understand trigger factors, whether the prodrome was present or any associated symptoms are there. We can do an ECG, a tilt table test, echocardiography, and of course, ambulatory monitoring of ECG, that is 24-hour Holter monitoring. Why do you want 24-hour Holter monitoring and Any other ambulatory monitoring that we require in a patient who is being evaluated for syncope? Anyone? So there are two ambulatory monitorings that are required. One is 24-hour Holter. Anything else? Come on, guys. You are preparing for MRCP exam.
Ambulatory BP monitoring.
Yes, ambulatory BP monitoring, ABPM. So, why ambulatory BP monitoring? Because orthostatic hypotension will start reflecting in that ambulatory BP monitoring. So, whenever a patient comes to you with syncope, after the initial assessment, what you do is you'll just look at the age group. If it is a young adult or an adolescent with no comorbidities or risk factors, compatible symptoms, and alternatives are unlikely, then you should consider neurally mediated, usually in females. And there are more chances that these patients can have, a supraventricular arrhythmia. So you can try a carotid sinus massage. And in case the carotid sinus massage will again cause a syncope, then the patient has a disease known as carotid sinus sensitivity. But if carotid sinus massage does not cause syncope, then it is vasovagus reflex vasodependence. Then comes the other factors where you do an ECG, and if the ECG is normal, we call it orthostatic uh, assessment is important. So we do orthostatic. If the orthostatic changes are present, we do a hemogram to see if there is anemia, because sometimes GI blood losses, patients present with syncope every time they have a GI blood loss. Like every time they pass melena, they have syncope before that. So the history is like I had a syncope, then I woke up, and the moment I woke up, I was having blood in my stools. Then, of course, if hemogram is normal, then we call it orthostatic hypotension due to dehydration, volume loss, and drug induced. In a normal ECG with absent orthostatic changes, we can focus on neurally mediated, low venous return, outflow obstruction, focal neurological symptoms, and metabolic patterns of presentation. In metabolic, we need to rule out blood glucose, low blood glucose, that is hypoglycemia. And yes, adrenal insufficiency, which is known as Addison's disease, can manifest as a metabolic source of syncope. Because of, in Addison's disease, what do we have? We have hyponatremia, we have hypoglycemia, we have hypotension. It is only potassium which is high. Other than that, everything else is hypotension. Then the hypothermia. So these patients who have Addisonian crisis or Addison's disease can also present with syncope. Then people who have no orthostatic changes, but they presented with syncope-like features, and focal neurological symptoms, may be weakness of a limb or maybe jerky movements. We do a CT head, and in case there is any specific finding, we can identify stroke, TIA, SAH, and complex migraines in CT head. Otherwise, what we'll do is we'll get an EEG done. And in case we get an EEG done and we find that there is a seizure activity, then this syncope becomes seizure. Then we define it as epilepsy. Okay. Now, whenever there is an outflow obstruction suddenly, like in HOCM, like in pulmonary artery occlusion, definitely patient will have a syncope. So outflow obstruction from the pulmonary end, we'll like to do a pulmonary CTA and an echocardiography. In pulmonary CT angiogram, we'll find out about pulmonary embolism. And in echocardiography, we can find out dissection of aorta, valvular stenosis like aortic stenosis, or HCM. So these are all potential cardiac causes which can cause syncope. Of course, in case of venous return, we would like to see if there is any beta HCG levels are increased, for example, in pregnancy, or in echocardiography ultrasound, if we can find out that there is a pericardial tamponade. In pericardial tamponade, syncope is a very, very common presentation. Patient, right now I have two patients in my cardiac unit who presented with syncope but evaluated to have a massive pericardial tamponade. The reasons were, one was uremic, the other was having breast malignancy. So pregnancy and tamponade. Now, in cases where ECG is directly abnormal, we can consider dysarrhythmia. and we need 24-hour ECG or maybe a loop recorder for 7 days, and we can identify arrhythmia and then start antiarrhythmics. Again, an abnormal ECG does not necessarily mean that the patient has arrhythmia. It may have ischemia, it may have a complete heart block, and we need to see because ischemia can lead to sudden ventricular tachycardias, which may not be reflected in immediate ECG. So, for that, of course, you will need continuous monitoring and troponin levels, and then you will reach to a conclusion. Is this algorithm helpful to you for identifying syncope? Yes?
Yes,
So
sir.
basically, immediately you should find out if there are any reversible causes and you should get an ECG. In case ECG is normal, think about other causes like metabolic, like orthostatic, like something in the brain, neurological syncope, something in the heart, structural heart disease, or something outside the heart like tamponade. And of course, if ECG has some changes, these changes can be arrhythmia related or they can be ischemia related. If it is an ischemia related, then you should rule out by the process of, that algorithm, that get a echocardiogram baseline. If still not convinced, then get a stress echo, or then you can take up for CT angiogram or a coronary angiogram. Okay. So once we are done with the basic work, let's see some questions. A 72-year-old man collapses while shaving. This question, I don't know how many times it has appeared in MRCP exam. A 72-year-old man collapses while shaving. He reports no prodrome but feels lightheaded after turning his neck. Physical exam reveals a regular pulse of 70. ECG is normal. What is the most likely diagnosis?
Carotid sinus hypersensitivity.
Perfect. So let's go back to the let's go back to this algorithm. So we found out that our patient has carotid sinus sensitivity. So in case you want to diagnose this patient, what will you perform? Which test will you perform in the OPD? You will do have everything ready. So a carotid sinus massage. In case you do a carotid sinus massage, we will find out syncope that is triggered by neck movement or carotid pressure is characteristic. So diagnosis is confirmed. So it is the question you can get is how to confirm. Confirmation is by carotid sinus massage showing asystole or significant bradycardia. So you should do it in a setup where you have everything like defibrillator, adrenaline, atropine, intubation, immediate transvenous pacing. So everything you should be having.